This is one of the most important tasks and a must-to-know task in the exam, as you all know, because every one of you is going to encounter this task in your exam, right? This can be challenging to start with, but once you have practiced it for a considerable period of time, it can be tactical and it can be easy to go about these tasks. So people who are in serious practice, that is who we are targeting today. This session is for those who have been in the practice for quite some time now. And for beginners, please take it as a sensitization so that you will get an idea how to go about. So Dr. Priyanka, you should be ready now. For 2 minutes, you will be going over the board and I'll start you with the 10-minute timer. And by the time you finish, I will let you know the 10 minutes is up. And if you're not able to finish because we are in the initial stage of preparation, I'll give you further time also. Okay. So we shall be able to finish the whole board for now. Okay. So this is the plan for today. All right. And whatever feedback that we are going to give, please take it in the constructive side and don't be too critical. Don't let it weigh upon you too much. Okay. So we are in the initial time of preparation. So we shall take it in the constructive side. So with that, I'll not waste much time. I'll go into the 2-minute time. Okay. That's your time, dear.
Okay. Hello, I'm Priyanka. I'm ready. So I have
Can go
taken the
on.
Labour Ward charge. I have taken the Labour Ward charge at 8 a.m. and I have my staff available and I want to need the competency level of my ST1, ST2 and also need to know the availability of the course and the level of an ICU and also access to the emergency obstetrical theatre. And after giving a panoramic view in the Labour Ward, I can see there is a high priority task in room number 4 and also in the room number 5, but I would like to go room wise and ask few details and then for my final prioritization. So room number 1, I can see there is a multi-gravida patient now who has delivered in the home. So I want to know patient's current observations of her abdominal elevation findings and the vaginal elevation findings, any bleeding, and the baby condition.
Delivered 1 hour ago and her pulse is 94, blood pressure is 100/70 and baby is in SICU, SBCU and baby is on CPAP and there is no active bleeding as such.
Uterus contracted?
Uterus is contracted. Her estimated blood loss so far is mentioned to be 1200 ml.
Okay. So it is at the moment it is an high priority semi-urgent case. I will send my as it is blood loss is still is bleeding patient.
Patient has no further bleeding. Her pulse is 94 and BP 170. No active bleeding at
Okay.
present.
Okay, at the moment it is an low priority semi-urgent case. I will send my ST1 or midwife there to follow up the patient according to the news chart and send investigation. There is full blood count to know the hemoglobin level, if necessary, blood transfusion, and continue oxytocin infusion if it is continuing, and also arrange for the scab of the baby. So in the room number 2, I can see there is a patient who is primary given 38 weeks in complex social circumstances. I want to know about patient's vitals, abdominal vaginal findings, and what about the complex social circumstance.
So she is alone. She's 17-year-old. She has missed appointments and she is on cannabis and cocaine as she's taking those drugs as an abuse. Temporary accommodation she is from. No safeguarding assessment has been done so far. Her contractions are 3 for 10 minutes and FH is 140 per minute. She's 5 centimeter dilated and she's on Entonox.
Okay. So it is also an operative emergent case. I will send one of my mediators there to continue the monitoring of the progress of the labor and also arrange for the safeguarding and support for this teenage girl and also connect with to the some support services. That is the alcohol and the cocaine reduction or sedation services. Then the room number 3, there is a patient who is came for induction of labor. Her blood pressure is 150/90. So I want to know patient's current observation. Have induction is already started, abdominal and vaginal admission findings.
She's 35 plus 5 weeks now. You're talking about room number 3, right?
Yes, IUFG.
35 plus 5 weeks. And she's complaining of severe headache now. PCR is elevated. Her BP is 150/90. And per abdomen uterus is 34 week size, no contractions. It's non-tender.
Okay. Any induction has been started?
Not yet.
Okay, so it is an high priority urgent case. I will send my ST2 and the ST5 anesthesia in that room, and the task is here, giving an IV access, whole blood count, liver function test, kidney function test, coagulation profile, and give her injection levodopa, and also give her for the control of blood pressure and injection magnesium sulfate to prevention of eclampsia, and also once the monitor the patient, once patient condition is stabilized, then do NCTG and the Bishop scoring for finalization her mode of the delivery. So room number 4, there is a patient who is to labor to deliver 15 minutes back. So I want to know patient's current observation, abdominal elevation findings, and the vaginal elevation findings. Any investigation or treatment started?
So she delivered 15 minutes ago. Her placenta delivery is complete. No excess blood loss is seen. Heart rate is 120. BP is 100/65. Respiratory rate is 28. SpO2 is found to be 93% room air. Temperature is found to be normal. Nothing further is done so far.
Uterus contracted.
Uterus is contracted.
And
Estimated blood loss is 400 ml so far. There is a continuous trickle noted.
Okay. So this is an hypertension case. I will go myself there after giving a panoramic view in the Labour Ward, keeping patient safety. And I will ask also my consultant to attend immediately and input the MDT, including restrictive anesthesia also. And I will start the resuscitation of the patient according to measure obstetrical hemorrhage protocol, airway, breathing, circulation, and opening of IB channel by 2 wide bore IB cannula, blood group save, and full blood count liver kidney function test, and continue oxytocin infusion, start uterine masses and catheterization, and give oxytocin medication in a stepwise manner. If not controlled, then patient should be shifted to the operation theater, balloon tamponade, and if not controlled, then
okay. Now the saturation is
there is
84% on oxygen.
Okay, so this is an emergency case. This might be a case of amniotic fluid embolism or pulmonary embolism. So shift the patient to the ICU also and inform the anesthetic team and give the resuscitation as by 100% oxygen by airway, maintaining the airway breathing and the circulation. And now the patient is room number 5. That is a patient who is 39 weeks, came with abdominal pain, with P, vaginal discharge. Okay, I want to know patient's current vitals, abdominal, and the vaginal evacuation findings, and the CTG.
Okay, so she is a gravida 2, para 1, life 0. And she delivered previously a term intrauterine fetal death baby. And right now she has a pinkish vaginal discharge. And abdominal findings, she has contractions and uterus is found to be tense. Cervix is unapaced, bleeding seen through the os. CTG
Okay.
you'll be seeing now. Are you
Okay,
able to
and
see the
any
CTG?
ultrasound? Yes. Okay, so this is an pathological CTG. And so I want to know any ultrasound findings of the placenta position available?
Placenta is found to be fundal. Growth had been normal so far.
Okay. Okay, so it might be a case of abrasive placenta. So it is also an hyperterrogen case. I will ask my consultant immediately to attend this case as I'm busy in another room. And also the task is here, do an IV access, blood is sent for full blood count group save, and start IV fluid and catheterization, and do and gentle speculum examination to exclude any local cause and shift the patient to the operation theater. Ma'am, can I know the vitals of this patient?
Vitals right now, it is holding dear. 160 per minute FH and pulse and blood pressure are holding.
Okay, so based on the heart vitals and as the patient CTG is pathological, I'll shift the patient to the operation theater for the category 1 cesarean and also for category 1 cesarean. And now coming to the next one, ma'am, previous please. Previous page, ma'am.
Yes, dear. Just a moment. Don't worry about it. I'll see, it's a little bit slow. I moved. Able to see now?
Yes.
Yeah, go on.
Okay, so the next room, this is a patient who is a primary catheter and pregnancy, spontaneous labor. So I want to know patient's current vitals, abdominal and the vaginal evacuation findings and the CTG findings, and patient is requesting for epidural.
Yeah. 6 centimeter dilated. She was on intermittent auscultation so far. Maternal observations are all normal. Anesthetist has not been informed so far. Okay, so it is a low priority semi-urgent case. I will send my midwife and the ST5 anesthesia in that room or my ST1. And the task is here. My anesthetic will assess the patient and give the epidural. And also I will, and my midwife will do monitor the liver progress. And the room number 7, there is a patient who is waiting for induction. I want to know patient's current vitals and the indication for the induction and abdominal and vaginal examination findings and the CTG. So she is a primey, 42 plus 3, hence she was induced. CTG is found to be normal. Bishop is 3. Okay. Okay. Right now your time is up, but still we will continue. Okay. Okay. A low priority emergent case. I will send one of the emergent case. I will send one of the midwife there to monitor the labor progress. And sorry, this is not in. So yeah, it's okay. Yeah. Ma'am, I haven't called again and again, so it is. That is all right. Okay. So, that is all right. Okay. Okay. So this patient is the patient is induced, ma'am? Not yet, dear. She's planned for
Okay, so it is
induction.
a low
She's
priority.
awaiting induction. Yeah.
Okay, so it is a low priority non-urgent case. I'll send one of my midwife there to assess the patient by doing the CTG and the Bishop scoring, and according to that, plan for and do the apology. And the room number
Okay.
8, there is a patient who is in postnatal second degree waiting for repair. So I want to know patient's current vitals, abdominal, and the based on admission findings, estimated blood loss.
Stable observations, estimated blood loss is 300 ml, and it's a second degree tier. Baby is doing well.
Okay, so it is in low priority emergent case. I will send my ST1 there or midwife there according to their competency level and do the apology to the patient and for the delay and repair the tear in the labor room. Labor room. That is, so my high priority case in room number 3, where I will send my ST2 and ST5 anesthesia, and then the room number 4, where I will attend myself, and in the room number 5, I will send my consultant. Thank you for taking.
Okay. Well done, dear. Please, dear Dr. Priyanka, tell me how it was so far.
I cannot finish, so it is not good.
No, actually, it is good because you were able to finish the high priority rooms. The rest of the rooms, it was low priority. And by the time it was ending towards 10, you were able to finish much of the important rooms. So that is all right. Then, what is your other concern, if you have any? You tell me your positives, what went well with you, you thought. A lot of things went well.
Yeah.
Most of the points you were able to say. You were methodical. You did not miss the priority. You did not miss delegation. Some fine tuning is always there, definitely. Till the exams, it will be going on. Nobody is 100% perfect. Yes?
Yes.
Sumi, what is your take? Could you please join in?
Ma'am, I think sometimes I take time to understand the things, and it will fill my time more.
Okay, probably it's over Zoom. It might be the reason. If you see a person in front of you telling you the vitals and things, I don't think that will be a problem because you know whatever is happening, you know what to do in the next step as well, right? So that should not be a problem. Okay. Yeah.
Yes.
So let us be looking at each room and how you did it and how you can use some keywords to make it more appealing and more exam oriented, right? So that during the exams, when you utter those phrases and you are showcasing that will give you the edge over anybody who is going to do the same way, right? So there are certain keywords which you would need to use for any particular room or any particular situation. So the timing, how you approach the case, how you utilize the time for each room, and how you prioritize according to the situation. And with new information thrown in, how you're able to regroup yourself. And at the same time, without compromising the safety, right? That matters. And most of the points you were able to mention. So it was a well done station. Now, coming to the way in which you started the opening, right? The opening, it's better not to be very long. You can just go on with, I'm taking over. I have with me my colleagues. According to the level of competency, I'll be delegating the tasks and you can go on. And the NICU, the theater availability. So that is like an umbrella statement you were mentioning there. But for each case where the theater is required, again, you will need to mention it there. So this kind of umbrella statement, it is always better to avoid. That is not going to fetch you any marks. And it's not used also, like it is not marked and it is not like you are smart in saying those points. So everyone will ask you to mention that, but not mentioning that is not going to downscore you at all. So be smart in your approach and utilize every second of those 10 minutes, right? That is going to help you manage a room. Okay. And for non-urgent and semi-urgent rooms, practice in a way so that you are able to give the desired points in the shortest time possible. If at all, it will be very basic, like waiting induction, waiting suturing, right? So, or termination, waiting to start the termination process. So something like that would be there for which you practice so that you utilize the least time possible. Okay. And for the high priority rooms, make sure you finish the whole management part. Suppose if it is a PPH going on, it's better to finish the whole PPH management rather than for that point of time. For rest of the rooms, the very next step is enough for you to mention. Okay. Are you with me so far?
Yes, ma'am.
Yes. So your approach of going room by room is all right. It's not wrong. But when you have a high priority room in front of you, it's always best to mention it. I know everyone out there is telling you each and every single way that fits them or if they think is perfect. But when you are in the labor room and when you see a patient is having possibly a blood loss or possibly a pink fluid from the vagina, right? Or somebody is not feeling well. So something like that is going on. Bells will be ringing in your ears that you will have to go there, right? So you will have to mention that. So initially you mentioned it like there are high priority rooms, but still I want to go room by room. That is an okay approach. But since not many number of rooms are there, it's better to go there and finish it off and then come back to the other rooms. Sometimes you might think you might miss off certain rooms. Yes, that is a good approach when you have a lot of rooms. Suppose 10 rooms are there and somebody is awaiting transfer and then there is another patient HDU. If such is there, then you can go room by room. But for a labor room where the information is very less and something is glaring at you that this could be an ongoing emergency, go to it and finish it off. And sometimes if they say that right now there is no bleeding, it's all right. It's just that you have finished that room and you move on to the other things like you actually do in the labor room. If you go and see in the labor room, if something is going on the board, you will be asking naturally. That's the first question in your mind, right? So just do the same way. Okay. So whatever approach fits you, stick to that and don't change because somebody told this way or that way. Okay. So that is there. So now coming to your approach, the first room you wanted to go for was the number one room in the board. So this one was a patient who delivered vaginally and it was a home birth. And the questions you asked were appropriate. How much was the blood loss? And the points which I have highlighted are the points you mentioned. And most of the points you mentioned, sometimes I might not have highlighted, but still you would have mentioned. I'll be going by simultaneously. All right. Yes. So are you following me?
Okay.
Yeah.
Yes.
So this slide is visible, right? So the first room, this was a home birth, and you asked the maternal observations and the blood loss. And the information which I gave you was she delivered an hour ago, and the estimated blood loss is 1,200. So here the keyword is how much was the estimated blood loss. Make sure you mention this in any PPH station or any APH station. The estimation of blood loss, how much is the blood loss, you need to ask for it. Be very specific in that number. And instead of asking this, the observations you mentioned, what the observation you want, like pulse BP, it's not going to take much time. Some people used to ask, what are the vitals, any other info. So instead of that, you were particular, you were specific in your questions you wanted, you asked from me. So that is good. And so any patient who has delivered, make sure whether the placenta has been completely removed or not. So that question is very important because there could be retained placenta as well, right? So make sure for any patient who are delivered and some information is missing about the placental delivery, you check the completeness of placental removal, okay? And the uterus removed or not. So other things you were able to ask, you did ask. So the management, you rightly mentioned that it doesn't need any active input now, but you will be monitoring it. You rightly allocated the ST1 to continue with the observations, and midwife also could monitor it. And later on, you can put in one word like consultant can be informed, right? And you will be reviewing the observations because you have asked the ST1 to review right now, but you will be getting back to it. You can just put in one word, okay? And other things, these are not very much relevant, not very wrong to miss this. So this is all right. And room 2, it was a safeguarding concern. You rightly delegated it to midwife, and ST1, you involved the safeguarding lead. For any 17-year-old, if there is any complex social factors going on, what factor, you rightly asked that. And this, I think I myself mentioned the safeguarding lead hasn't seen the patient yet. So that you would need to mention for any underage girl coming in labor, whether she has had any previous checkup at all in the antenatal care, anything was she received at all, right? So that needs to be mentioned. And this assessment also, you mentioned that you will be carrying in view of the substance abuse that she was doing. And one more important safety aspect is the infection screen. Because she has been not receiving any antenatal care, you would need to do a rapid assessment of infections, right? You would need to rule out HIV, the rapid test you need to do. Okay, so that is one thing which was missing here. Now, room number 3 was IUFD with features of preeclampsia. Any preeclampsia, you specifically mention whether she has any imminent signs and symptoms. Okay, that is one of the important things. And whether repeat BP was done. One BP is given to you as 150/90. What if the BP has gone up and you missed to repeat it, mention it, right? So make sure you mention the repeat BP. Okay, and the management was appropriate. Like you ordered the full bloods. Magnesium sulfate was also started. And whenever you are mentioning magnesium sulfate, mention that she will be monitored for toxicity also for magnesium sulfate. You rightly gave the antihypertensive. It could be IV. It's not wrong. And you also talked about how you will plan for the delivery. That is all right. Okay. So because there is an IUFT and the preeclampsia has been going on, you mentioned the PAPV findings. I just told you Bishop 3 and then other things have been all right. So you ruled out abruption also. So that was fine. And she's in the labor room, so level 2 care, that is all right. But the important thing is what is the blood group? In your IUFT, blood group is important to be mentioned. And if because she is O negative, she would require anti-D to be given right now because it is IUFT. So this needs to be mentioned. Okay. It's just
Okay.
play with the information, whether you are thinking about it at that point of time or not. That's all. It's not like you don't know to give anti-D for a RH negative patient. Just whether you are thinking about it is the matter there. Now for the collapse patient, current observations you rightly asked. And initially, when this room air is 93%, at that point of time itself, you can mention whether this could be AFE. Because I told you 84% on oxygen, that's the time when you went to the AFE, massive PE. You rightly mentioned the differentials, very good, because people will just mention amniotic fluid embolism only. They will not mention the pulmonary embolism as a DD at all. You rightly mentioned. And the other differentials also, please keep in mind the sepsis, could be anaphylaxis as well, we cannot know, right? So mention 2-3 differentials, okay? But the management was appropriate, right? Management, you mentioned that you will be going on by yourself and you will be calling the anesthetist. But then the anesthetist was present in 2 places. So what you can mention is anesthetist, because it is a collapse and amniotic fluid embolism is going on, anesthetist is most importantly needed at this point here in this room. Okay, for IUFD, there is no need for anesthetist right away. Agreed?
Okay.
Agreed?
Yes, ma'am.
So here for the IUFT, you can ask the ST2 to review because it is preeclampsia and she has headache. Definitely you would need somebody to stabilize and to start with the magnesium sulfate and take the bloods and get the initial arrangements ready. So ST2 will be stabilizing the patient here. At the same time, yourself along with the anesthetist, ST5, can manage the patient who has suspected AFE. The products
Okay.
and the ICU, all those things, everything that you rightly mentioned. What other suggestion I would want to tell you is, for any high priority, high top urgent case like this, make sure you complete the whole management part. You can take 2 to 3 minutes for this room. And by practice, the rest of the non-urgent rooms, you should be able to tell in 20 to 30 seconds. Okay, two rooms, you can mention in 20 to 30 seconds. That is possible. Okay, so the rest of the points you are able to say, make sure you mention certain, key phrases like kind of the continuous monitoring. Yeah, you can mention consultant anesthetist. For pulmonary embolism, yes, you can mention, but whoever is there along with you, it's better to mention them, right? Rather than somebody who is not here or not mentioned in the team, which is along with you. It's what you can say is you can mobilize like that. You can mention, you can call for is what you can mention. But right now with you need the anesthetist ST5 because that person is there with you. So this is the first time. This is the first thing you would need to mention. And the consultant is held up in theater, right? So since the consultant is held up in theater, you cannot delegate any work to the consultant. At present, you will be stabilizing the patient. You will be informing the consultant and finding out what is happening in the theater, whether it is going to be complete, whether the consultant will be able to join us, or you would want to, because there are 2 simultaneous emergencies going on, you would want to call in anybody else to help you, right? So that needs to be mentioned. It's not like you are mentioning somebody who is not in the board or not given it to you in the candidate instructions. It's just that you are recognizing and acknowledging that 2 simultaneous emergencies, more than 2 life-threatening emergencies are going on and you would need hands. So that needs to be verbalized. Okay. And for rooms like this, make sure you mention the incident reporting, documentation, ongoing care, and the debriefing team. So another keyword which I wanted you to mention was the CRMA. CRMA is communication, resuscitation, management, assessment, and suppose if the patient is bleeding, arrest of bleeding. So this needs to be mentioned. So the management, communication, assessment, everything will go on simultaneously. Okay, so this needs to be mentioned. Okay, yes?
Okay.
Yeah, the meeting is about. So most of these points you were able to mention. See, another thing is monitoring. How you are going to monitor? You are going to monitor by repeating FBC, PTA, PTT, fibrinogen, and make sure you mention the blood products and mention that she has no reservations for transfusion. So these are the things you should never miss. Okay. So the initial time, it's all right, but towards your exams, these are the points which should come to you even if somebody is asking you in your sleep. All right. So after ruling out allergy, after ruling out reservations for transfusion, these are things you should always mention. Now coming to the pink vaginal discharge with reduced fetal movements. Now, another keyword you would need to mention for any of the maternal and the fetal patient hasn't delivered, and you are supposed to talk about the risk assessment. Maternal and fetal risk assessment is something you would need to mention in these stations, be it preeclampsia, fetal growth restriction, or somebody with reduced fetal movements, right? Or CTG is suspicious, or something like that is going on. You mentioned the risk assessment. So that is telling the examiner that you are looking at the patient overall. You're looking at the background. Okay. So, and this patient had a previous IUD, and this patient is a gravida too. So this was not mentioned in the this thing, right? In the board, right? The parity was not mentioned.
Yes.
So which information is not given there also you need to pick up. That is part of information gathering. Sometimes what will happen is they might mention a previous delivery was cesarean section, and right now they will show you an abnormal CTG, and that might be something like a pointer for a rupture. Okay, so you should not miss it there, right? So you would need to be asking
Okay.
about the parity, and if the gravida status is not given, you definitely need to mention it there. Okay, so this one was previous term IUD. So background something is going on, you will be aware. And right now, since she has something other than the show, you rightly picked it up. It is not show. So you rightly asked about the fundus, the placenta, whether it is previa also. This you rightly asked, and the observations also you asked. The CTG I showed, and CTG you mentioned what it is. So this is a pathological CTG you rightly mentioned, and you mentioned the category 1 cesarean section also, because this patient is not going to deliver anytime soon. So this category 1 cesarean section, very well done. You rightly mentioned this. So the urgency, who is going to do that? Was where the urgency also you mentioned, but you mentioned the consultant will be taking up, right? The consultant is there in the theater, and initial resuscitation only can be done by somebody. It could be ST1 or ST2. If ST2 is in the preeclampsia room, you can ask the ST1. Or if the ST1 is in the preeclampsia room, you can ask the ST2. Okay, but they will not be doing the case. They will be doing the initial assessment. Then this is where you have to say that a lot of things are going on. I would need somebody else also. I would need to know how the consultant is going in the theater, whether they will be able to take up this case there, right? So this is the complete management that you are showcasing there. Okay.
Okay.
So the room number 5 for the pinkish vaginal discharge, make sure you ask for the parity and categorize the CTG and mention the urgency. And because there is nobody to take up this case, you need somebody to take up this case, and make sure you mention the pediatric team also. Initially, you told whether the cots are available for the NICU beds. But for any category 1 cesarean section or FH is problematic like this, make sure you mention the neonatal team also. Okay. And because this is a concealed abruption, make sure you mention the blood and blood products. This you mentioned, IV access, you need to attend urgently. All these things you rightly mentioned. Okay. Now coming to the rest of the rooms. Requesting epidural, this was a straightforward case. So by the time you came here, that was the time when the time ran out. So not so bad. Most of the things you were able to say previously. So these are the things which you would need to be telling very fast. You should not think it should come from the spinal reflex only. When somebody is requesting epidural, make sure you start the IV line. Top up should be ready. Continuous CTG should be ready, right? Bloods should be, the blood investigation results should be there, and inform the anesthetist team. And monitoring midwife is fine, and continuous CTG should be there. Fine. So this you would need to mention. And for the next room 7, again, it was a non-urgent room. You rightly mentioned. Review the waiting list and capacity. Both of the rooms you were able to apologize, perform the duty of candor. And for any induction, previously how the CTG was, what is the bishop, the indication, most of the points you mentioned, right? The indication for induction and what is the bishop right now, and pre-induction and post-induction CTG, the consent, group and save. These are the routine things you would be mentioning. Okay. So the ST1 can take forward once the emergencies are taken care of. So this you can mention. Once the emergencies are taken care of, these are the rooms which we will be looking at and reviewing. And lastly, second degree tear. This is again, it could be looking very, benign, But once you go there, sometimes it will turn into a slow trickle where patient has gone into DIC, or it could be a retained placenta, or it could be an inversion as well, or it could be an oasis as well, right? So make sure you ask for certain things like what is the blood loss, whether the placental delivery is complete, okay, what is the observation right now, how the mother is doing, how the baby is. So these are things fast you mention. So here, the points which you mentioned were you offered apology and you asked a midwife can suture. So here also you mentioned ST1. So instead of that, for any secondary criteria, midwife is fine. But then you yourself corrected it, and then you mentioned midwife can repair according to competency. So that was all right. Midwife can repair. So post repair, make sure you mention this PR, post repair advice and analgesia. So these are the things you will have to mention for any benign case like this also. So finally, your prioritization, because it is top urgent, you will be going to the room 4 along with the anesthetist ST5. Simultaneously, because there is another fetal compromise going on, your ST2 is going to stabilize the patient, and somebody is going to take it up in the theater. Because you are held up and there are 2 life-threatening emergencies, you are alerting somebody else should be coming in. Okay. And lead resuscitation in room 4 by yourself, ST2 to urgent assessment of room 5, where this the hypertension along with the headache is going on, and ST1 to stable but urgent reviews. So these are all the things you were able to do. Should immediately escalate for consultant, additional senior support. So this is how you go about. Very well done.
Thank you, ma'am. Yes, ma'am, in room number 5, I will
Yeah.
send my ST2
Yeah.
for
Yeah.
stabilization of the patient
Yeah.
and shift
Yeah.
the patient to the operation theater for
Yes.
category of cesarean section. Then
Yes.
cesarean section will be done by my consultant or another consultant.
That is what you have to verbalize that, because consultant is
Okay.
mentioned to be in theater. It might have been a surgery that consultant might have started right now, or he might be finishing it off. It could be anywhere in the surgery. So you have to verbalize that, because consultant is held up in theater, I will assess whether consultant will be able to join, or do I have to call in somebody else, because it is 2 life-threatening emergencies are going on and I'm not able to go there, and it is only ST2. You did not go for any unsafe behavior like asking the ST2 to go for this kind of cesarean section, right? It could
No, no,
be
ma'am.
an abruption,
Yes.
right? It could be a very heavy bleeding. Patient could lose the life. And so you did not go
Ma'am,
for that answer. Yeah.
ma'am, if I say I will inform my consultant to attend this case for
No, that
category
is
of cesarean
also
section,
not.
will
Yeah,
that
yeah,
be
yeah,
okay?
yeah. That is also not possible, because what if the consultant is washed up and just now the consultant has started the surgery? He'll not be able to be there simultaneously for 2 cases.
Okay.
So don't go for something which you don't know information about. You don't
Then
know, you
I
don't have
can
any
say
further
that
information.
I will ask for another consultant as my
Additional
consultant is
backup.
busy in the
Yes.
theater.
Yes. I will
Yes.
ask for
Ask for
additional backup.
another consultant.
Yes, I'll ask for additional backup. I'll inform the labor ward coordinator, because through life-threatening emergencies are going on. So that you verbalize. It's not like you are asking
Okay.
for somebody who is not given. You are just telling that you need hands. There is a shortage crisis going on. That's it.
Okay.
Right?
Okay.
Yeah. Yes, dear. Hello, dear Shruti.
Good, ma'am.
It was good.
Yes,
She,
ma'am.
she presented well, right? Most of the points our friend
Yes.
was able to mention.
Yes,
Rightly, her
yes.
approach was good. Like in terms of situation, what she rightly recognized it. And she asked for assessments, and she mentioned the urgency, and she went in for the management step. But sometimes what can happen is, once the assessment is given, with that, it's better to, give the status of urgency. With the initial part itself, if you assess the urgency, level of urgency, sometimes you could be wrong. So she rightly mentioned after assessment, so this is top priority, this is a semi-urgent. So this, she mentioned it even without, even at the stage of, her preparation. So that was very well done. So suppose, because this patient who delivered vaginally, her estimated blood loss was more than 1,000, right? But still she was able to mention that right now she is holding, it's all right, but post PPH care needs to be mentioned. So we will be doing that. We'll be continuing monitoring. So her assessment followed by urgency prioritization and allotment of resources was very appropriate. Sumi, do you have, please add how it went?
Thank you, Meera. And Dr. Priyanka, it was a very well done station. It was very organized, and you were really very calm during your presentation. Yeah, I was really impressed here. My points, all of them, Meera has covered. So there is nothing much that I would also need to add. I just wanted to tell about the introduction, just a few points, and everything Meera has covered. Very well done, dear.
Yeah, time and again, the candidates think that initially, if we are able to mention those points, it will be applicable to the rooms. But that's not going to help at all. That's going to take your time. And also that I am so and so coming in for group the discussion, structured discussion. I'm ready to start. That is also not going to help.
Exactly. Actually, you had taken 30 seconds for the introduction. Instead of that, you could have covered maybe one or two non-urgent stations. You could.
Exactly. Yeah. So usually non-urgent rooms, you should be able to finish 2 rooms in 20 to 30 seconds. That's how you should practice. Fast, you should mention and move on. And another way to say is a situation. Instead of reading out the whole information from there, 17-year-old, primey, 38 weeks, complex social circumstances. So there's a teenage with complex social circumstances. They go straight away. So this, okay. You rightly followed the S-bar pattern because people will be starting with this is an urgent room. I'll be delegating this. Her management steps are. So that is wrong. That is a wrong approach. These points we need not tell you at all. You were able to mention all that. So this is essentially like a reflex. This is the labor room prioritization task is like a reflex operation. Once something is given to you, how you imagine yourself in that situation, what are all the next steps you would need to do in terms of urgency, in terms of priority, what are all the points you say. It need not be long sentences, just the next steps in terms of keywords you should be able to mention and ask the right questions. Don't ask overall umbrella questions like, I want to know her vitals, what is her status right now. Instead of that, be very specific, because some key points like the estimated blood loss, whether the placenta is complete or not. So those points, unless and until you mention, they will not be telling you what is her saturation, what is her status right now. This you mentioned while even going on, you asked that question, what is her status right now. So, and so those patients where CTG needs to be complete, make sure you mention that monitoring aspect also. This is something which can be forgotten. The management will be done, the continued monitoring, MEOS charting, VT risk assessment, those things will be overlooked. So make sure you mention those also. Don't forget about incident reporting. Okay, don't forget about the clinical governance aspect. Don't forget about talking to the patient. Suppose you're taking her to theater, inform the patient about the current status. Ask whether the patient knows about the IUFT status at all. Okay, whether this information was told to her. So she should be in a private room. Rule out any acute concerns right now, whether she is in any pain. So those are the things you would need to be mentioning there. Okay. As such, for labor room, you would need individual attention. You would need a feedback for your own self, which will be helpful to you. At the same time, you keep listening to a lot of trials by others as well. Small tidbits, how others mention certain things in a shorter way or in a more smart way. You would need to be incorporating those as well. So that is like a continuous inflow of. It's a process how you present this labor ward prioritization task. And sometimes what can happen is, despite all the preparation that you do on the exam day, sometimes people might not be very much happy with how you go about. Suppose, for example, an examiner might not like the way that you are going room by room. He or she might expect you to go to the most urgent room. So they will be put off and they'll be irritated. So those things, those kind of instances can also happen. Don't be put off. Regroup yourself and go by whatever needs to be done at that point of time, right? So that can also happen as well. So here we are actually very thrilled to announce this workshop where we are planning to help you people to practice on individual labor ward stations so that you will be able to, address any kind of emergencies given to you. So this is not like any other stations where a whole station is given and the whole feedback will be given. This is like a workshop where you will be addressing how to communicate, how to put forth that information in a very smart way, at the same time not missing out on the key aspects of the management. Okay, so this we are thrilled to announce, and we will be giving you the dates also once around the exam booking. This should help you. So thank you everyone for watching.